Hello everyone, my name is Trevor Cox and I am a candidate for the Masters in Applied Nutrition for University of New England. And in this presentation, I will be evaluating the impact of L-carnitine supplementation. I have included an overview for my presentation on the impact of L-carnitine supplementation that highlight the key points that I will be reviewing. This includes the introduction, methodology, research findings, discussion, implication of findings, and references. Beginning with the introduction, I would like to define L-carnitine. This is a branched-chain, non-essential amino acid that is synthesized from the essential amino acids lysine and methionine. L-carnitine plays a vital role in energy production and fatty acid metabolism. There is primary carnitine deficiency and also secondary carnitine deficiency. Primary carnitine deficiency can lead to muscle weakness. 1 in 100,000 newborns are born with primary carnitine deficiency. Moving into my second portion of my introduction, L-carnitine is derived from many common food sources, and this includes meat, poultry, fish, and dairy products. 75% of carnitine is obtained from the diet, but can also be obtained through supplementation. This is absorbed from foods via active and passive transport. The Food and Nutrition Board has not established DRIs or RDAs for carnitine as it is non-essential but plays a vital role in many human functions. For this systematic review, I chose to ask the research question as stated. Among adults equal to or greater than 18 years old with equal to or greater than a 25 BMI, how does oral L-carnitine supplementation affect LDL cholesterol and hemoglobin A1C? For the population, it is adults above or equal to the age of 18 with a greater than or equal to 25 BMI. The intervention is oral L-carnitine supplementation. The comparison is a placebo group, and the outcomes are LDL cholesterol and hemoglobin A1C. Next, we will move into the methodology of this presentation. Looking at the study criteria, the inclusion criteria includes equal to or greater than 18 years old for the subjects, oral L-carnitine supplementation, equal to or greater than 25 BMI, randomized controlled study, and research after 2008. Exclusion criteria include below the age of 18, intravenous L-carnitine supplementation, less than 25 BMI, non-randomized controlled studies, and research prior to 2018. Moving into the systematic review for the research findings, I examined 4 studies. The first is from Brules YM, titled Carnitine Supplementation Improves Metabolic Flexibility in Skeletal Muscle Acetylcarnitine Formation in Volunteers with Impaired Glucose Tolerance. The next is from Parvanova A, and is titled Blood Pressure and Metabolic Effects of Acetyl L-carnitine in Type 2 Diabetes. The next is from Bloomer RJ, entitled Effect of Oral Acetyl L-carnitine Arginate on Resting and Postprandial Blood Biomarkers in Prediabetics. And the last study I examined is from Malgar Nero and is titled L-carnitine Supplementation Reduces Oxidized LDL Cholesterol in Patients with Diabetes. The first study that I examined is titled Carnitine Supplementation Improves Metabolic Flexibility in Skeletal Muscle Acetylcarnitine carnitine formation in volunteers with impaired glucose tolerance. This was a randomized controlled trial. This was over the duration of 36 days and examined 23 adults aged 59 through 64 years old with greater than or equal to a BMI of 25. The intervention was 2,000 milligrams of oral L-carnitine per day over the course of this 36-day trial. The control group was taking a placebo, and this was assessed at baseline, 7, 14, 21, 28, 33, and 36 days. This study found that hemoglobin A1C was not significantly improved in the intervention group when compared to the placebo group. This was statistically insignificant with a p-value of 0.9. The LDL cholesterol was also examined in this study and also showed no improvement. And this was also statistically insignificant with a p-value of 0.6. The second study that I examined was titled Blood Pressure and Metabolic Effects of Acetyl L-Carnitine in Type 2 Diabetes. This was a randomized controlled trial over the course of 6 months with 229 adults over the age of 40 years old and equal to or greater than a BMI of 25. The intervention group received 1,000 milligrams of oral L-carnitine per day. The control group received a placebo. The results from this study were assessed at baseline, 1, 3, and 6 months. The results from this study found that hemoglobin A1C significantly increased in both intervention and control group. This was statistically significant with a p-value equal to 0.0230. The LDL cholesterol was also examined in this study and was found to be not significantly different in the intervention group when compared to the placebo group. And this was statistically insignificant with a p-value greater than 0.05. The third study that I examined was titled Effect of Oral Acetyl L-Carnitine Arginate on Resting and Postprandial Blood Biomarkers in Prediabetics. This was a randomized controlled trial over the course of 2 months and included 29 adults aged 20 through 55 years old with equal or greater than a BMI of 25. The intervention was 1,350 milligrams of oral L-carnitine and 1,200 milligrams of oral arginine per day over the course of 2 months. The control group took a placebo, and the results of this study were examined and assessed at baseline, 1, and 2 months. The results of this third study are as followed. Hemoglobin A1C was slightly improved in the intervention group when compared to the placebo group. This was statistically significant with a p-value of less than 0.05. The LDL cholesterol was not improved in the intervention group when compared to the placebo group. This was statistically insignificant with a p-value of greater than 0.05. The fourth and final study that I reviewed in this systematic review was titled L-carnitine supplementation reduces oxidized LDL cholesterol in patients with diabetes. This was a randomized controlled trial with a time frame of 3 months and had 81 adults aged 20 through 70 years old with above or equal to a BMI of 25 that participated in this study. The intervention group was 2,000 milligrams of oral L-carnitine per day over the course of this trial. The control group was taking a placebo, and the results were evaluated and assessed at baseline, 1, 2, and 3 months. The findings of this fourth and final study found that hemoglobin A1C was significantly improved in the intervention group when compared to the placebo group. And this was statistically significant with a p-value of less than 0.001. LDL cholesterol decreased by 0.45 compared with 0.16 mmol per liter, and this was the intervention and placebo group respectively. And this was statistically significant with a p-value less than 0.001. To synthesize and summarize the results for this systematic review, I have developed this chart that reports the key findings. To reiterate the research question, it is as follows. Among adults equal to or above the age of 18 years old with equal to or above a BMI of 25, how does oral L-carnitine supplementation affect LDL cholesterol and hemoglobin A1C? The intervention was oral L-carnitine supplementation, and the 4 trials ranged from a dosage of 1,000 milligrams per day to 2,000 milligrams per day. In the comparison, in all of these trials were a placebo, and the study period looked at 1 through 6 months. The outcomes showed that hemoglobin A1C was significantly increased in 3 of the trials, and there were significant improvements in LDL cholesterol in 1 of the trials. For this systematic review, my conclusion of the findings report daily oral L-carnitine supplementation improves LDL cholesterol and hemoglobin A1C in adults equal to or above the age of 18 years old with equal to or above a BMI of 25. Moving into the discussion portion of this presentation, I wanted to review my findings and assess the strengths and limitations. First, looking at the strengths. There is strong evidence to show improvements in both LDL cholesterol and hemoglobin A1C. These studies evaluated diverse populations from different countries, including Netherlands, USA, and Italy. All of the 4 studies were randomized, double-blind, and placebo-controlled, which fit into my inclusion criteria for the studies that I was looking to examine. And also to note that there were no serious adverse effects in any of the 4 studies. It is important to discuss the limitations of a systematic review as this identifies areas in which results and conclusions may be skewed. First, the Brules YM and Bloomer RJ research studies had a sample size of under 30 individuals. Bloomer RJ examined the effects of L-carnitine arginate, which is a combination of L-carnitine and arginine, which may have skewed the results in this study and is hard to determine the effects of L-carnitine independently. The duration of treatment between studies was wide, ranging from 36 days to 6 months. Lastly, the dosage of treatment between studies was wide, ranging from 1,000 to 2,000 milligrams of L-carnitine. To conclude my presentation, I would like to look at the implications of findings and the future research. Below I have derived a list of questions that I believe would further the research in L-carnitine supplementation. My first question is, What are the cardiometabolic outcomes of L-carnitine supplementation in adults equal to or greater than 18 years old with equal to or greater than a BMI of 25? My second question is, among children below the age of 18 years old, how does oral L-carnitine supplementation affect LDL cholesterol and hemoglobin A1C? And lastly, I would like to look at specifically the dosage of L-carnitine supplementation, as the 4 studies that were included in this systematic review examined dosages from 1,000 to 2,000 milligrams. And so the last question, would a dosage of above 2,000 milligrams of L-carnitine supplementation daily for 1 to 6 months result in different outcomes when examining LDL cholesterol and hemoglobin A1C? Thank you.